Okay. It's always a challenge to try to give these virtual presentations. I'm so used to having people in front of me when I speak. And so just sort of looking at the slides and talking into my laptop is always a challenge. But I'd like to thank Joy, Carolina, and Robin, and Lori for inviting me to talk today. And I look forward to your questions at the end. So the NINDS, its mission, one of its mission or its major mission is to, it has a commitment to reducing the disproportionate burden of neurological disease borne by underserved groups of society, including racial and ethnic minorities, rural and socioeconomically disadvantaged populations, by funding a spectrum of research from basic science through clinical studies and training the next generation of health disparities investigators. This addition to our mission statement was actually created after a planning panel was put together in 2010 by the Institute director at that time to address health disparities, since it's a growing problem here in the United States and in the world. There are a lot of health inequities. So that's why that mission statement was created at that time. More recently, I started with the NINDS, started back with the NINDS actually in August of 2019, and helped to create an office within the Division of Clinical Research. It's the Office of Global Health and Health Disparities. We deal with both. The major focus of our office is to sort of lead the coordination and development of programs and initiatives that foster national and international research on disparities and inequities and neurological diseases. We also, we work specifically with low and middle income countries to build capacity, sustainable capacity for them to do research and also export beyond research to management of public health challenges in these countries. We also support bilateral partnerships between the United States and middle and high income countries in research areas of mutual interest. For instance, some of the larger clinical trials that led to the approval of the embolectomy procedure for large vessel occlusions, there were international sites that participated in these as well. So there is interest for us to also collaborate with high income countries that have more established research centers, and also advancing research and tailored interventions related to health disparities in underserved communities here in the United States as well. In our underserved communities, we look at race, ethnic differences, rural, socioeconomic populations, also sexual and gender minorities as well. So we deal with all of those in my office. Just to list some of the research projects that we funded in the past related to health disparities. There's a large study called REGARDS that was run by George Howard. It's looking at geographic and racial differences in stroke in whites and blacks in the US. The Northern Manhattan Stroke Study is a long-running study. Actually, it was the first study to look at stroke in a tri-ethnic community in Northern Manhattan. Blacks, whites, and Hispanics. This was led initially by Dr. Ralph Sacco. I actually did my stroke fellowship with Dr. Sacco and worked on NOMAS for 2 years at that time. And we have the BASIC study as well, which looked at stroke in Hispanics versus whites as well. And then a lot of other studies. Just to highlight another, we have interventions as well, like the Hip Hop Stroke Program, which is an intervention for middle school kids, and it's teaching stroke readiness to kids in the middle school, and it's been shown to have sustainable knowledge and readiness in that population. They're actually looking for this information as well to trickle up to parents as well in their stroke readiness or ability to call 911 if they actually see a person having a stroke. So these are just some of the things that we funded in the past. At the NINDS, we also have some training programs. We have the Brains, the Transcends program, which is a program to try to increase the number of neurologists doing research. And so it's a great program that I actually am the program director for, as well as a training program. It's a collaboration between the American Heart Association and the NINDS, and it's called the Heads Up. We actually had our first meeting in February at the International Stroke Conference in LA, and several publications came out of this. We published all of the abstracts from the attendees that participated in this International Stroke Conference meeting. And then some of the speakers are also publishing their talks as well. And so very fruitful. So that was a very good program as well for training. Right now at the NINDS, I mentioned that in 2010, the director at that time put together a planning panel to try to advise the Institute on what it should do related to health disparities. They put out a report in 2012, and then some of those programs that I just mentioned came out of that planning effort. And so now we're in 2020, and so we're going through another process of planning, strategic planning for health disparities at the NINDS. In this phase, we're trying to focus more on health equity. The term disparities has sort of a negative connotation associated with it. What we really want is to create a state of equity. We have health disparities population has been thrown around. And when you talk about a population with health disparities, I think that suggests that there are certain stigma or stereotypes that are attached to certain populations that stigmatize certain groups, and we don't want to do that. And so that term health disparities population sounds sort of negative. So we'd like to move away from that. What we really want is to create equity, not equality. If you look here at the first part of the slide, if you have people with certain biologic inherent differences, or for whatever reason, their differences, if you give the same thing to each person, you're still not creating the state of equity. You have to truly get equity, you may have to give a little bit more to some who may be height challenged, and someone who doesn't have that issue with height may not require anything at that time. So in this phase of our planning, what we're looking to is establishing a state of equity. And this, through working to achieve health equity, it improves the healthcare for everyone in the United States. One of the initiatives that we have now through our office deals with maternal mortality. When you look at maternal mortality in the United States, which we are a developed high-income country, we actually are in the middle of high-income countries in terms of our maternal mortality rate. And so that's not good. You would think that we'd be at the top of the list, but for every population in this race ethnic population in the United States, we're in the middle overall. However, it is worse. We do see that it's worse for certain race ethnic groups in terms of maternal mortality. So by improving or addressing that issue related to maternal mortality, we can improve the mortality rate for all race ethnic groups in the United States. And so that's what we think about when we talk about health equity. And so as part of this process, what we've done is we've put together a committee of experts from around the country. Some of them are from our National Advisory Board. We have 2 people from that, our National Advisory Board. And then we have other experts from around the country that are looking to help advise us and come up with recommendations related to health disparities. We're actually using a framework that was created by the National Institute of Minority Health and Health Disparities. And it looks at various social and biologic factors and how those impact us on an individual level, a family level, a local level, and even a national level. And so through that, we've created a chart that we're going to use as a framework to do a portfolio analysis. with this, we've created a work group at NINDS of all of our program analysts, program directors with various specialties in the various neurological disorders. We're going to look at over a period of time, 5 or 10 years, the types of research that we funded, and we're going to put those into certain baskets and categories and see what type of work we funded. What is it dealing with? Is it looking at biologic determinants of health disparities? Is it looking at social determinants? And if so, what type of determinant? Is it an intervention? Is it an observational study? And so we're going to do a lot of analysis. Is it looking at rural versus geographic differences, race ethnic differences, gender differences? And so we'd like to look at all of those various things. And so that's what we're going to do with our portfolio analysis. We also have a request for information that's out now. And if, you know, at the end of the talk, if anyone would like to submit information, just let us know. We can send you the link. Request for information is a way that the federal government sort of gets input from the community. We like input from patients, from family members, special interest groups, nurses, providers, advanced practice practitioners, all kinds of input in as to different race, ethnic, gender, regional, geographic, or care issues in the country. When I was at the International Stroke Conference this past February, I had a conversation with one of my previous stroke fellow trainees. He's now an attending in West Virginia. And so he is a stroke neurologist. His wife is also a neurologist, but they were saying how difficult it is to refer patients to certain specialties in neurology because they just don't have those types of specialists there. And so they have to send their patients miles and miles, in some instances from West Virginia into Maryland, DC, or Virginia in order to see a subspecialist in a particular area of neurology. And so we like to look at those too, because I think that's important. We know that there are regional and geographic differences that create disparities or inequities in healthcare in the United States as well. We've also created a trans NIH group. NINDS is one of 27 institutes at the NIH, and we also have offices and centers as well. And so we have about 17 other NIH institutes and centers that are working with us as well. We have individuals from those institutes that have an interest in health disparities, and we are asking them about their how they addressed health disparities at their institute, what types of factors they looked at, and how they went about it. Hopefully through this endeavor, we'll be able to come up with some type of announcements that we can use in the future, trans NIH announcements or funding announcements to address multiple areas of health disparities, even beyond neurological disparities. We're culminating this process with a workshop that will take place September 23rd and 24th of 2021. It's going to take place in the Natural Auditorium on the main NIH campus. And at that workshop, what we're planning to do is to sort of talk about those major areas of overlap. We're going to talk about interventions that have worked. Our institute director now is interested not in just defining disparities that are out there, but taking interventions that work and implementing them in various communities and trying to scale up these interventions to try to really decrease the disparities that we see. And so at this particular workshop, that's what we plan to do, to sort of discuss the types of interventions that we need, bring in the proper collaborations, including other government agencies, pharma, and private HMOs as well to address, because it takes all of these various agencies working together to address these disparities. The other piece of when you talk about health disparities, it's important to have diversity because diverse populations, having any diverse group brings in a diversity of ideas and a diversity of ways of attacking a problem. And through doing that, you actually end up with a better outcome as opposed to everyone with the same ideas. And so diversity matters. The NINDS is dedicated to a biomedical research environment that reflects the nation's diversity. Most people from every background here in this country pays taxes, and so they should have the benefit of those taxes in terms of the being at the table when it comes to these research efforts. We actually have an office at the NINDS that focuses on this, but I'm going to talk about this in the next few slides as well. I think this will be important for this group as well to hear. We like to recruit the most talented researchers from all groups in the country and improve the quality of educational training. So we have some training programs to deal with diversity. And this sort of gives a balanced perspective in terms of research setting, as I mentioned, and an improved capacity to address health disparities, as I just mentioned as well. So the NIH defines diversity as individuals from underrepresented, so again, that's underrepresented racial and ethnic groups. There are certain minority groups that are not underrepresented in science and medicine. And so this is focusing on underrepresented racial and ethnic groups, individuals with disabilities, and that's defined as physical or mental impairment, and individuals from disadvantaged backgrounds, socially, culturally, economically, or emotionally. And the disadvantaged category is only applicable to high school and undergraduate candidates. We have various levels of training for diverse individuals. We have R25 training programs. We have reentry programs for people who are out of the workforce and want to come in, diverse people for that. We have them for various levels, career stages from high school all the way up to faculty members. We have K01 and K22 awards. I'll talk about these a little bit more. And these are some of the other mechanisms that we have as well. Some of the awards are institutional awards, and then individual awards. I have those listed here. And I imagine you guys can get a copy of these slides so you can see those. Look at these in your leisure. And then also we have institutional awards as well. And then we have something called supplements to promote diversity. I mention this because a lot of people, whenever I talk about this, this for some investigators is sort of a black box, but individuals who are funded through most NIH institutes, including the NINDS, if someone has an investigator has an R, P, or U funds from our institute, they can apply for a diversity supplement in order to help train a diverse individual from that particular institution. They just have to say from what category of diversity that individual comes from. And it's typically 2 years worth of funding. They can be bridge funds for an individual, or just a way to start a small research project to hopefully get data to apply for larger funds. And these are reviewed internally at the NINDS in batches 3 times per year. We also have training awards. We have one that's a advanced postdoctoral award. So this is an award that's given K22 to diverse individuals. It's between 2 to 5 years. The first phase of the award is at the end of the postdoctoral experience. And the second phase is sort of a transition to faculty. So when this application is written with the project during the postdoctoral phase, and then you sort of plan the type of work that you'll work on doing your first faculty position. And then the other is a K01, which is a faculty development award. So this is someone that's already a faculty member within 5 years. It'll provide up to 5 years of support. And it can occur in the first 3 years of a faculty position. And so those are two types of training awards that we have for diverse individuals as well. The office that we have that deals with diversity is called Open. They have a lot of social media. They actually have a podcast that's really nice that was created by two people from that office. And it's great if you go to and listen to these podcasts. They actually go through the various, really fun to listen to. I've listened to them. And they talk about the various stages of the NIH process and submitting an application as well. Here are some of the episodes listed here. So really good. So I really suggest that you go to the site. And if you have any particular question about diversity training as well, you can go to the Open website as well. So I'm going to stop right there and take questions if you have any.
Just as a reminder, you can use the chat box link at the bottom or Q&A as well.
So yeah, if you have questions, either speak up or someone can read a question to me because I can't see the chat.
Hey, Dr. Benson, Will Moyer here. Thank you so much for this excellent presentation. I will sort of, as we await more questions from the audience that we can read to you, one question that occurred to me is, do you think you could speak more on the idea of the workforce reentry grants at the faculty level? I wasn't as familiar with those, and I'm interested in knowing more about how those are structured and what you would look at as candidates for those sorts of program grants.
So there are specific criteria that that you have to meet in order to apply. Let's say that a mother who's a researcher had to take time off in order to deliver and care for a child, or someone has a family member, an elderly family member that he or she has to take care of, then you can apply for that type of award, and it took you away from doing your research for a period of time. Then that's what those awards are for. And there are specific criteria, because I know there are all kinds of questions that come up in terms of who can apply for that. But it would be sort of a bridging funds to get you back if some type of retooling is needed to get back up to the speed in your research. Then that would those funds could support you during that period of time. Again, if there are more specific questions, I would direct you to the Open office to discuss those.
Dr. Benson, we had a question. If you could put the Yoda screen back on during the question and answer portion, because they missed the podcast info.
Okay.
And then could Dr. Benson give an example of an intervention to reduce health inequity that was noted to be particularly effective with slightly greater detail? What features did you feel that was that said intervention have that set it apart or made it significantly effective?
That's a great question. Can the person who asked that question sort of expound on that? Because I can answer that a couple of ways.
Yoni, or you can unmute yourself.
Sure. Good afternoon, Dr. Benson. Thank you for the talk. It was definitely just plain awesome. So I think what I'm getting at is kind of, we hear a lot about these various interventions. We hear a lot about the inequities, and I was wondering if you could kind of zone in on just one example that really seemed to turn things around or had a significant impact in the more so in the long term, the outcomes that we look for. And what do you think was the factor that kind of set that apart?
Okay, that's a great question. And I will answer it both ways. So one is with hypertension control. There's been a lot of work done through Kaiser looking at hypertension control. They found that if you can get, and they did this in the Kaiser system, and so this is actually one intervention that we have to export. They clearly showed that doing this intervention, you can decrease hypertension disparities. And through getting people to monitor their blood pressure individually at least twice a month, and then to set them up with an intermediary between their provider, like a pharmacist or a nurse, to help them to adjust their blood pressure medications when needed. So just the intervention of people checking their blood pressure twice a month, and then having a pharmacist or a nurse who's able to review that information and adjust the blood pressure medication in between the doctor visits. That intervention has been shown to work. And then you can include as well patient training about diet and nutrition and those kinds of things as well. And so that type of intervention has been shown to work. And so through the American Heart Association, they've created several programs. There's one called Target BP, and some other programs that they've tried to introduce across the country for people to modify those programs in different ways to try to do those interventions. So that's one, blood pressure management. And we know that hypertension disproportionately affects African Americans in the United States, and it's highly prevalent above the age of 50. The rates of hypertension start to increase to the point that 1 in every 3 or 1 in every 2 adults have hypertension. And that's every race ethnic group. But it disproportionately affects people of color as well. Now, the other way to answer that is that the question that we often get when you look at health disparities, for a long time we had focused on biologic determinants, but there are a lot of social determinants as well. And so one question that I got, and I didn't know if you were alluding to this, is how do you address social determinants in research? And so one, for instance, we know that decreased fruit and vegetable intake is associated with a higher rate of stroke and heart attack. We know that there are food deserts throughout the country. Certain communities don't have access to fresh fruits and vegetables. And so how do you address that? Well, one way that it's being addressed is there's a program through the American Heart Association where they're going to certain major grocery stores, and they're getting the fruits and vegetables that have not been sold. They can, let's say you have a package of 12 tomatoes, they can't, just because of regulations, separate those and sell 2 tomatoes. They have to sell them as a package. And if they don't sell them by a certain time, then they throw them away. So there are organizations that actually go and get the food. They examine it to make sure that it's still healthy and nutritious, and they can repackage it and take it and give it out to certain communities that don't have fresh fruits and vegetables. Also, they've been looking at going to grade schools and middle schools. They have a lot of fresh fruits and vegetables that are put on the trays, and kids will throw them in the trash. They'll go and take they'll look at the fruits and vegetables and make sure that they're not damaged and that they're healthy, and that they'll put them out because some kids don't have breakfast available in the morning. And so they'll offer them to people in the morning. So that's a way to do an intervention to try to address decreased fruit and vegetable intake, which is a social determinant of health. And so there are ways there are interventions. We know that there are disparities. And so what we'd like to do is to look at those, and that's what we're doing now in our portfolio analysis and through talking with our program directors and other investigators to say what other interventions are out there besides this blood pressure intervention that works, and how can we modify and tailor those throughout the country as well. Does that answer your question?
Yes, thank you. I very much appreciate it, and the elaboration with the specificity, because I think for me, that's always one of the questions, because to your point, it has to be tailored to the problem, the intervention, the challenges that the community is facing, along with all of the other biological aspects. And so it becomes multi-layered very quickly. And yet at the same time, you know, to your point, also translating it across different forums is absolutely critical to, you know, working on the scope. So thank you again.
Thank you. And that was actually the term multi-layered intervention. And that's actually the term that we use. And so the framework, I actually should have put that slide up there of the framework, but with this framework to evaluate biologic and social determinants of these health disparities, you can actually look at the framework and then create those multi-layered interventions in a systematic way. And so I like the terminology that you used.
This is Lori. This is Lori Gutman. Thanks for a great talk. Good, good. Always good to hear you talk. I was curious on what you think, how you think telehealth may affect health inequities, the pros and cons, especially now that we're having to use it more and more. I've heard that it may address health inequities, but in other disparities, and other times people say that it doesn't.
Actually, that's a great question, Lori. And actually, I've had that discussion with some extramural investigators, and they're actually looking at that particular question. There is a benefit to, well, actually, this is another one that I can answer in several different ways because it brings up, so it's just a great question. Number one, you know, going through this period where we've moved a lot of healthcare to telehealth, we've created a situation where people said, well, people are starting to think and say, well, if I can see my doctor virtually and not have to take time off work or time out of my day to go to the doctor, why do I need to go to the doctor? Why can't I just have a virtual visit? And so I think that question will have to be addressed in terms of, you know, what type of visits are appropriate for a televisit and what type of visit. Obviously, if you need a procedure or something checked, then you have to go in. But I think medicine will eventually have to change from that standpoint. So that's one issue, and that's going to impact doctors. And I know now that people are actually doing televisits where they're asking people to do sort of portions of the exam that you can do visually, but you can't listen. Right now, we don't have the technology to listen to the heart or the lungs virtually. But you can check the blood pressure actually and upload that. The other piece is that there are people who have access to the technology and are able to use the technology to do the televisits, but we know that there are others who aren't. And we think that this may also create a disparity moving forward, because a disparity related to socioeconomics, education, and also race, ethnicity. And so that's something that we'll have to look at to see, are we now creating a situation where, you know, we can actually look at this time period and say who missed doctor visits because they weren't able to do a televisit and they were told not to make an in-person visit to go and see their doctor. I think people are looking at that now to see if we are creating another area of disparity. I think education may be a modifying factor and socioeconomic status, but unfortunately, because of higher rates of decreased education and lower SES and certain race ethnic groups, those groups with the lower SES and education are probably those who won't have the access to the televisits as much. But it's a very interesting topic in terms of how it's impacting medicine. But then the other fact, how medicine is practiced, is also the other issue that providers are going to have to look at that too. Do you actually need to come in to get your blood pressure checked? Is a lot of doctors, and I know there are other physicians and other providers on the call. Sometimes people would go to the doctor and the physician actually never really touched the patient. In neurology, you have to do that, but in certain specialties, that doesn't happen. So again, you know, I think how medicine is practiced is also going to change moving forward. But that's a whole nother issue, but that's a great point, Lori.
I just want to mention that there was a couple links to a podcast and Twitter link up here that if anyone had interest here to look at that in the chat box. Are there any other questions or comments?
And I'm sure you can get my email, or if someone can send it out to you. And if you have any other questions, then please feel free to email me. Or if you have any ideas or thoughts or any questions about the training programs or any of our announcements, we actually have a listserv for my office that we're creating, where we're going to send out announcements and updates about health disparities as well. And you can get the same thing from the training office, diversity training office, and our regular training office. Thank you. I'm going to stop sharing my screen.
Thank you, Dr. Benson. That was really good. Will, do you want to?
Yeah, so we're going to transition to the next part of our talk now. We have a previously given presentation by Drs. Conwit and Dr. Mendoza-Puccini, which I'm going to briefly, which is a little bit less than 10 minutes, which will leave us a little bit of time afterwards for questions about the common data elements. For those who've been coming to some of the other CTMC webinars, I did not speed this one up. This is at natural speed. I took out a couple pauses, but this video is not doctored. So let me get that going. All right. And you should be able to hear this starting just about.
In my many years of experience at NIH and NINDS, I can say that this CD project is an excellent opportunity to standardize clinical research data, as well as harmonizing efforts that are extremely important and do increase efficiency. As many of you know, this CDE contract is a major NINDS initiative with many, many meetings and iterations. Alex can attest to this as well. This project is actually like the Constitution of the United States. It keeps changing and evolving. And most recently, it's been evolving in a positive direction as Carolina Mendoza-Puccini at NINDS is now in charge and has taken the helm as the program director for the CDE.
So I'm going to tell you a little about what is the CDE project, or the Common Data Elements project. So this project started about 10 years ago. Actually, NINDS was one of the pioneers developing these tools. And the project was to develop the data standards for clinical research in neuroscience. So the common data elements are content standards and can be applied to various data collection models. And as Robin mentioned before, they're very dynamic and evolve over time. But CDEs are not a database, and I will talk about that later. So the goals of the project are to develop common definitions and standardized case report forms, or CRFs, and other data collection instruments. And they also help investigators to conduct clinical research through the development of these uniform formats by which clinical data can be systematically collected, analyzed, and shared across the research community.
We want to make sure that data is comparable.
Exactly. Okay. At NINDS level, we use, or we ask our grantees, and it's in the term of awards, that they use the common data elements when they do phase 3 clinical trials and exploratory trials. So usually UO1 are required. And the clinical research project will be accelerated, and new investigators can build consensus data elements. They can start up multi-center and international clinical research efforts that will be streamlined.
So if you don't use them, you need to explain why you're not utilizing the CDE.
Exactly, but there has to be a very strong reason why not to use them. For example, will be that we haven't developed CDs for that particular disease. That's the strongest reason, exactly. So a little bit of definitions. What is a data element? So it's an information that describes a piece of data to be collected in a study. And a common data element, or CD, is a data element that is common to multiple data sets that are going to be used across different studies. And these are definitions from the National Library of Medicine. And a CD is going to include a name, a precise definition, a semantic value, with clear definitions and permissible values. And they're consistent and harmonized across different data sets. Next. So the way we define the CDs and the way we ask the grantees to use them is the following. We have a general core that is going to be used across all diseases. They're general CDs like demographics, medical history, etc. And they're going to be required for all NINDS funded studies, the ones that I mentioned before. Then the next layer is a core that they're CDs specific to that particular disease that are also going to be required. Then the supplemental highly recommended that are important tools that the expert decided that will be great to have them in the study, however, they're not required. Then the supplemental that they're less important in the way they categorize them, the experts, and the investigators can choose and pick what instruments they want to use. And the exploratory, they're just tools that are not validated for that disease or they're not validated at all. However, they may be important to include them in a study. We currently have over 20 disease areas, so there are about 18,000 CDs and 1,400 instruments in total. So we have cerebral palsy, Chiari-1, epilepsy, headache, mitral disease. In movement disorders, we have Parkinson's and Huntington's, MS, ME/CFS. In the neuromuscular diseases, we have ALS, Friedreich's ataxia. In the muscular dystrophies, we have Duchenne, FSH. We also have myasthenia, spinal muscular atrophy, and then spinal cord injury. In stroke, we have other subcategories. TBI, we have sport-related concussion, and biomechanical devices in TBI. And some of them have pediatric CDs. So the development process, this is very quick. So we initially identify CDs, develop and vet them by a group of experts from that scientific community. Then we have collaborative involvement from other NIH institutes, other federal agencies like National Library of Medicine, CDC, DOD, etc. We also have collaboration with industry and patient advocacy groups. Whenever possible, we're aligned with other international data standards, and Alex will talk about that later, like CDISC or ISO. And NINDS, our role is to provide continued guidance, review, and oversight in general of the project. Next. So these are the development steps. I'm not going to go through them, but in a nutshell, it takes about up to 18 months to develop CD. So it's not an easy process. Takes many meetings, as Roy mentioned before, a lot of time from the experts, which they do that in a volunteer basis. And then that's the timeline requires a lot of steps.
So initially we had these long CVE processes, and then we decided to go back and refine the core elements to pare it down, to make it even more efficient. So now we're going through essentially another period of growth.
Mm-hmm. And we revise every year all the CDs, all the diseases, and every year we try to develop a new one. Next. So these are potential benefits of CDs, and I can attest to that. I use them in a study, they work, and I will tell you some of the benefits. So, and I think the most important one is going to reduce time, it costs to develop the data collection tools. You're going to increase efficiency. You don't have to go and reinvent the wheel creating case report forms because they're already in the website and you can download them into several formats like PDF, CSV, Excel, etc. It's going to also reduce your startup time and the cost of your overall trial. You will not have to, and this is based on my personal experience, it will reduce the time of the meetings and aggravation of herding a bunch of people to decide what to add to your case report form. It's going to improve your data quality and facilitate data collection because you're going to use it across the study You're going to collect your data in a uniform way and a standardized manner. And also, it's going to make your study NINDS and NIH compliant. The CDs are not only used or developed by NINDS. There are many institutes that are also using them or in the process of developing them. They're also going to facilitate data sharing because the data set will be harmonized. And so it will reduce the time that you have to validate, like harmonize all your variables and go through all the steps to make your data sets analyzable. They're going to improve opportunities for validation of exploratory elements or instruments. If you have an instrument that you want to validate for a new purpose, a new disease, or a brand new instrument, that will be an opportunity maybe to use it in clinical trials for clinical trials readiness. And then it's going to also increase the CDE awareness in the neuroscience community through publications, presentations, and other ways to disseminate the usability in the neuroscience studies. Next.
One more thing, I was hoping we'd involve more young investigators in this process. We're hoping, and we can talk during the panel at the end, about ways to bring more ideas in and younger investigators.
And honestly, I wish I knew before I used the CDs for the first time in a stroke study that there were so many diseases, but it would have saved me a lot of time. And this is the website. Joy will post the slides. So the website, I'm happy to report that the current website is not as friendly as we wanted to. It was developed years ago. So it was time for us to work on a new website, and hopefully it will be up and running early next year. The contact information of our contractor, who they manage all the administrative part, my email and Robin's email. Feel free to email us or email me anytime for any questions that you have.
All right, and then we do not have Alex with us for the rest of this talk this time, but in the link to this, the YouTube video for the 2018 original presentation of this goes into some more details about, I think maybe some of you are asking, gosh, that was a very high level overview. What does this look like for a specific disease? And the latter part of the longer webinar in this does go into a lot of that detail. So I think with that, we'll hand the floor to Doctors Conwit and Mendoza-Puccini.
Okay, I have a few updates. You know, a lot of things have happened since 2018, I think was the talk. So we have a new process, not the RFI, of receiving nominations of new diseases. So there's a form that the person interested in nominating will complete with the program director at NINDS that has that topic in their portfolio. And I can give more information. We're waiting to post that online on our website. We have more diseases that we develop. We are currently developing rehab. We didn't release any new one, but we started developing CDs on rehabilitation in general. We developed pain CDs, and also we released a brand new revision of the stroke CDs. They were posted just, I think, a month ago, the final version. We're also developing, at the end of the year, we're going to revise the Parkinson's CD, the mitochondrial diseases, and we're going to create a brand new CDs that there aren't any, not even developed by any other groups, but that are coma and disorders of consciousness. So we're doing that with Neuroscience Society, Neurocritical Care Society. And if anyone is interested in participate as, one of the working groups, just contact me. Let's see what else. We also have a renewed interest in the CDs by NIH in general. It's now the CDs are included in the NIH Data Science Strategic Plan, also the National Library Medicine Strategic Plan. So we're going to probably have new projects and new opportunities, like funding opportunities. And I can keep you posted on that too. Also, due to the pandemic, that's part of the renewal of the interest in the CDs. One of the main goals, you know, when COVID-19 started to have these many cases, you know, we need to collect some data, especially focused on neurological manifestations. So we created an announcement for one of our data coordinating centers to tell them, okay, we want you to create a web portal so people can enter information. So that's coming. We're just starting to work on that. I'll also post to you, you know, and send the link whenever the website is ready. So I think that's like the update on the project. And do you have any questions? I do have some questions if people don't have questions. Things that I've had asked, you know, throughout.
Carolina, there's one in the chat.
Let me see. Is that in the Q&A?
In the chat, how is the concept of CDs different than common data models used by PCORNet?
Okay, so CDs are part of the common data, of a common data model. So a common data model is like a more bioinformatic concept that I don't have that expertise. I can give you like a very definition in lay terms. So what they do is that they create data standards and they tell their people, okay, these are the data standards that you're gonna use. And I think some of them use electronic health records. So what they do is that they collect that and they feed that into that common place. They collect all the data and then they like collate everything. And I don't know, it depends on what is the goal of the project. You know, they will send it to a central place. They will send it to a data repository. So I'm not completely familiar with PCORNet. You know, that's like a very non-informatic or non-bioinformatic definition. So that is the common, they call all that the common data model.
And just to build upon that response is that I think the key distinction is it's a way of mapping data that's really being collected in the health record and bringing it across different places through the PCORNet sort of data aggregation system so that, you know, variable names are the same and so forth. To use a sort of motivational example, you know, an example from the NINDS-CTMC would be if you're looking at mild TBI, you know, what sport were they playing and what are the choices? You know, was it soccer, football, baseball, cross country? You know, the CDE project, and I don't know if that's actually one of the NINDS-CTMC questions, but the idea of what is the structure of responses within a variable is part of the CDE project, whereas the PCORNet common data model is a way of harmonizing sort of already collected health data from other sources. Like how you would code the modified Rankin scale in a data set is there's a standard way of doing that with the CDEs, whereas in PCORNet, you know, that may well be defined, but it's really more focused on mapping sort of big ticket data items from existing data sources like the electronic health record.
Thank you, Will. And PCORNet is not the only CDM. There are many out there.
Yeah, and one other sort of idea or concept that uses some of the same terminology is there's also a core outcome set. You know, this is the COMET project, and these are mostly researchers out of the UK, although it is a worldwide collaboration. And in those, they try to come up with core outcomes that ought to be reported for every single clinical trial. For example, if it's a stroke trial, you want to record a baseline NIH stroke scale, you want to record a modified Rankin at 90 days. And it's a little bit more theoretical, whereas the CDEs really also take that additional step to ensuring that the data is entered in a way that the trials can have interoperable data sets. So it's sort of like a melding of the two concepts of the PCORNet common data model in some respects, and the global core outcome sets of here are outcomes you really want to record for you know, a specific clinical trial in a disease state, knowing that the CDEs are more comprehensive. You probably don't want to use every available variable from the NINDS TBI CDEs in your observational study of TBI. Having tried that and coded them all into REDCap, I was collecting way too much information for a brief observational study from the emergency department. So, but there are certainly ones that are very high level that you definitely don't want to miss. But don't think that you have to use every single outcome measure. It can end up being a lot, and not every outcome measure may be appropriate even in your disease state.
So I think I don't see any other questions, but in the meantime, we have a few minutes. In order to use the CDs, you don't have to be an NIH grantee. So basically, they're open access. Anyone can go to a website, look for case report forms, and download them. Since you're not an NIH grantee, then you can modify them. So it's not the ideal in some diseases like TBI. It's a good example of a disease that we're planning to revise because they have too many variables. It's too much. So that's one of the feedback that we got. You know, we have to trim them down and just put the core, like a very, just a few measures that we want to collect as core. But if you go to, I don't know, stroke, you know, you already have vetted that data that group of experts decided, okay, this is the data that you need to collect if you're doing a stroke trial. You do not miss this. So that's the idea. And you can just, you know, contact me if you have questions. Even though you're not an NIH grantee, you can contact me. This is a, you know, open access project.
Another question popped up, Carolina, in terms of how, oh, you saw it, okay.
Yeah.
The applications to other institutes.
So it's going to vary when you go from institute to institute. There are not that many institutes requiring the use of common data elements. However, you know, if you go to NCI, they do have their own CDEs and CTC-AE system, NHLBI too. So it's gonna vary. You know, some of them have developed CDEs, but they don't require them, and some of them require them. And how do they view it? You know, I think right now they are giving them more importance, or the importance that they should give in terms of harmonizing data.
And Dr. Fessel has given a really good framework. You know, a common data model is a broad organizing framework for data, typically from an electronic health record. How are things like gender or BP or other variables designated in a database? Whereas common data elements provide the definitions, response options, permitted values for those variables. And I do know that certainly NHLBI is working. I think initially asthma may be one of the first areas that they're working on CDEs as well within their institute.
And Chris also has another one, but it's already one. So yeah, I work with Josh, so.
Yeah, mine was not a question, it was just a clarification that another important point is the CDEs cover the structure, but not the name. So different data sets can use different names, but you could map the names together and they should have different structure. So it'd be easy to combine them if you're trying to combine them into a multi-use data set.
All right, Joy, you want to wrap up?
Yeah, so thank you, everyone. Thank you to our panelists today. Great presentations. I just want to remind everyone to evaluate this webinar because it does help us with future webinars. So make sure you do that, and the link is in the chat box. Also, our next webinar is on July 7th at 12 p.m. Eastern on rigor and transparency, and Dr. Lori Gutman will be the presenter for that. So thanks everyone for joining, and I will post the video and the slides from today on our webinar website probably within the next day or two. So if you know anyone who missed it, they can go there. So thank you.
Thank you.